Welcome to today's lesson on surgery and surgical nursing 3. Our topic for today is osteomyelitis. So what is osteomyelitis? It is an infection of the bone, usually caused by bacteria. The infection can be through extension of soft tissues. I'm talking about extension of soft tissue infection, example like incisional wound infection or vascularity. So what I'm trying to say here is that if you have a bone, bacteria getting access to a bone and getting the bone infected, I'm not sure any of you here will be considering the bone to look like a metal that doesn't get infected. No, bone is also tissues. It has blood, reaching its cells. It needs blood supply at all times. So the bone can get infected. And when a bone gets infected, we call it osteomyelitis. And what I'm saying is, these can be caused by infections by bacteria or even other organisms, but mostly by bacteria. And we're saying that the bacteria can get access to the bone through extension from soft tissue infection. So you have infection of some soft tissue, and then this has been able to get transmitted to the bone. And as a result of this, the bone gets infected. Direct bone contamination from bone surgery, open fracture or traumatic injury such as a gunshot wound. So what we're saying is, apart from the organisms extending from some soft tissues to the bone, you can also get infection through direct bone contamination, like you are performing a surgical intervention and then in the process you get the bone contaminated by maybe your unsterile instruments that you are using to perform the surgery. So the bone was touched in the process, and unfortunately bacterial organisms were introduced to this bone. So that is a direct form of contamination. It could also be direct contamination through open fracture or traumatic injury, such as you got involved in an accident, you fell from a height, and then you got a fracture, and this was a compound fracture. With a compound fracture, the bone is broken, the skin is open, the bone have access to the external environment. The bone is fully contaminated with maybe sand or soil around, and organisms are everywhere, so they get access to this bone. So this is a direct bone contamination. We can also have transmission of organisms through hematogenous means, that is blood to bone, which spread from other sites of infection. Say you have infection of, PID, pelvic inflammatory disease. The organisms that are causing the PID get access into the blood. As they are circulating within the blood, circulating through the blood, they eventually land on a bone in any part of the body, and then they start to get the bone infected. So this is spread by hematogenous means. Then we also have infection like tonsillitis or balls or upper respiratory tract infections, which may also get organisms transmitted to your bones. All right, let's look at incidence of osteomyelitis. Incidence. So osteomyelitis is common in children between the ages of 2 to 15 years, but it can occur in all ages. So it doesn't mean it is only those between the ages of 2 to 15 that gets osteomyelitis, but it is common among them. But any other person can also develop osteomyelitis, no matter your age. What are risk factors of osteomyelitis? Recent injury. So you have recent injury, you stand a very high chance of developing osteomyelitis. Obese people, so those who are obese mostly have, a form of immunocompromise to some extent, and then they stand a very high chance of developing infection too. So they stand a high chance of getting their bones infected. Then poor nutrition. If you have poor nutrition or you are not eating nutritious diets, you are always malnourished and your immunity is low, and you stand a high chance of developing infections, and this will further guarantee the fact that you can develop osteomyelitis. Then elderly people, so as we all know, as you age, your immunity starts to get compromised, or your immunity weakens. So, and we also have bones that get weakened through osteoporosis as we are aging. So when that happens, you stand a very high chance of developing problems of the bones. Patients with impaired immune systems with chronic illness, example diabetes, rheumatoid arthritis. So patients on long-term steroids, as you are on long-term, steroids for a long time, your immunity gets compromised, and this could lead you to developing infections. Then we have organisms associated with the infection include bacteria, staphylococcus, we have staphylococcus aureus, we have hemolytic streptococci, and then we have pneumococci. So these are organisms that are much more involved in osteomyelitis. Bone infections are more difficult to treat than soft tissue infections, and this is because the infected bone become walled off. Naturally, body immune response are blocked, and the area allows less penetration of antibiotics. So what we're saying here is, when you get tissue infection, soft tissue infection, like say pneumonia, that is infection of the lungs, or you have pyelonephritis, or you even have urinary tract infection, you can easily treat this simply because the body defenses, that is antibodies that are produced by the body to go in there and fight against the harmful organisms, the pathogenic organisms, can easily penetrate through the soft tissue to go and fight for you. But unfortunately, it is not like that in bones. When antibodies are produced in the body to go and fight pathogens in a bone setting, they are not able to penetrate through the bone. So because of that, the organisms are there without, opponents. The body soldiers are not able to get access to them to fight easily. Then we have another factor is that the antibiotics, when you give antibiotics or administer antibiotics, the antibiotics are very likely or is easily penetratable, or they are able to penetrate easily into soft tissues in order to fight the organisms. But it is not the same with bones, because the antibiotics are not able to penetrate through the bones easily. So if a bacteria is able to gain access to the bone and starts infection, it is very difficult to fight them off. So that is what makes bone infections much more difficult to treat. Now, Staphylococcus aureus causes about 70 to 80% of bone infections. We also have other pathogenic organisms which frequently found in osteomyelitis, and they are Proteus, Pseudomonas species, Escherichia coli. The incidence of penicillin resistance, nosocomial, gram-negative, and anaerobic infections are also increasing. So what we're saying here is we are just mentioning some of the pathogenic organisms that are much more likely to cause osteomyelitis. The initial response to infection is inflammation, which increases vascularity and edema. After 2 to 3 days, thrombosis of the blood vessels occurs in the area, resulting in ischemia with bone necrosis. The infection extends into the medullary cavity and under the periosteum. It may spread into adjacent soft tissues unless the infective process is treated promptly, and a bone abscess may form. So what we are trying to say is I'm just giving a basic pathophysiological background of osteomyelitis. So what I'm saying is, mostly when the organisms get access to the bone, initially the body responds. How does the body respond? Mostly the body responds to the presence of infections by an inflammatory process. That is when it increases blood circulation to the sites, try to send white blood cells, that is antibodies, to the site to be able to fight against the organisms. But in these situations, we know that these antibodies find it very difficult to penetrate through the bone to attack the organisms. And then mostly after 2 to 3 days, you have thrombosis of the blood vessels. You know, during inflammatory process, you have a lot of blood vessels opening up to the site. But within 2 to 3 days, then these blood vessels will form thrombus. There will be blood clots forming around these thrombus. and this result in ischemia. When we say ischemia, ischemia means that because of the thrombosis, you are no longer able to get fresh blood or blood reaching the site that is already infected. And this mostly will lead to bone necrosis. Once you are not having adequate blood supply reaching the part of the bone that is infected because of the thrombosis that has occurred, you are going to get the bone to die off, because the bone also need, that part of the bone also need blood to be able to survive or to live. Now the infection extends into the medullary. So the medullary is the internal part of the bone and under the periosteum, and this may spread to the adjacent soft tissues or joint, or unless the infective process is treated promptly, the bone abscess may form. So unless there is a way we are able to treat the necrosis of the bone that has occurred and is spreading to other soft tissues, spreading to the medulla, spreading to the periosteum, if we don't treat it immediately, or a way is not found to be able to treat it immediately, then we are going to have an abscess in the bone. And the abscess means that a part of the bone is going to get to die off, or to get necrosed, and then it will be walled off to form an abscess in there. A resulting abscess, like I've said, containing dead bone tissue, which we mostly refer to as sequestrum. So the dead bone tissue that can form as a result of the necrosis that has occurred, and there is cut of blood supply to the site, is what we refer to as a sequestrum. And this is formed which does not liquefy and drain. Therefore, the cavity cannot collapse and heal as occurs in soft tissues abscess. So when you have an abscess like a boil, let me take a boil into consideration. You have a boil, which is soft tissue infection. It mostly develop the abscess, form fluid, and later on it can break on its own, and then the fluid will drain. But the same does not apply to the bone. When an abscess forms in a bone, a part of the bone is dead, it is hiding within another part of the bone, and it remains there. It will not heal, and it will not also break down to drain out as it happens in soft tissues. So when this happens, a new bone growth forms and surrounds the sequestrum. So because the sequestrum or the dead bone is not able to break down and drain, a new bone may form, but it will surround the sequestrum, and the sequestrum will remain inside. Although healing appears to take place, a chronically infected sequestrum remains and produces recurring abscess throughout the patient's life. So you understand this. So this sequestrum, that is the dead piece of bone that is hiding inside the healthy new piece of bone that has formed, will be in there, and it will keep causing osteomyelitis upon osteomyelitis upon osteomyelitis throughout a person's life. Let's look at signs and symptoms of osteomyelitis. There is sudden onset, often with septicemia. There is chills, fever, rapid pulse, and general malaise is present. There is swelling at the affected area. There is pain and extreme tenderness. Pain intensifies with movement. How are we able to ascertain, or what are our diagnostic investigations we want to conduct in this situation? We want to do an X-ray, we want to do an MRI, we want to do bone CT scan, blood for culture and sensitivity, we want to do ESR, we want to do bone biopsy, we want to do our full blood count. Management. How do we manage osteomyelitis? We want to give antipyretics for temperature. Because of the fever, we want to give medications that will bring down the temperature. We want to give our intravenous fluids to nourish the patient. We want to transfuse if possible, that is hemotransfusion. The affected area is immobilized to decrease discomfort and to prevent pathologic fractures of weakened bone. So we want to make sure we immobilize the part that is affected, because we said there is severe pain and tenderness around that side. So the more the place is active and moving around, the higher or the severer the pain becomes. Apply a cast or splint to splint the affected part if possible. So we want to splint the affected part, we want to apply a cast to prevent the place from moving freely. IV antibiotics therapy is begun or is introduced as soon as culture specimen results are ready and switch to oral tabs for 3 months when infection is controlled. So what we're saying here is we start with our IV antibiotics. Once our culture lab is, our culture and sensitivity results are in, and we are able to tell the specific infectious agent that is causing the problem, we start our IV antibiotics. And as time goes on, when we assume it appropriate, we switch to oral antibiotics, which can be continued for as long as 3 months. IV clindamycin, ciprofloxacin are some antibiotics that are mostly given in this situation. Surgical management of osteomyelitis. You know, we said there is a sequestrum. A sequestrum is the dead piece of bone that is hiding in the healthy tissue of the bone, and it constantly keeps causing osteomyelitis upon osteomyelitis or regular infections. So we want to do a surgical intervention called sequestrectomy. Sequestrectomy. This is a surgical removal of dead bone. So we want to do a surgical intervention, and then we'll be able to remove the dead bone. After closure, cast can be applied with windows created to care for incision site. So when we were doing our cast application, we talked about windows or bivalving that can be done to ensure that there is not too much pressure created at the site, and also to have access to certain parts of the body that we can dress or take care of. Sometimes catheter is inserted to irrigate using antibiotics. Incision and drainage can also be done. What are some complications of osteomyelitis? We have pathologic fractures, we have septic arthritis, and then we have bone deformity. So we zoom to osteoporosis. Osteoporosis. Now, when you say osteoporosis, what do we mean? It is a reduction of total bone mass and a change in bone structure, which increases susceptibility to fracture. The normal homeostatic bone turnover changes the rate of bone formation, resulting in reduced total bone mass. Basically put, what I'm trying to say about osteoporosis is that it is a situation whereby the size of the bone, or the mass, the size, the width of the bone tend to change, and it change in terms of like decreasing in size. And when this happens, the bone becomes thinner. The mass of the bone loses its mass size, and then it becomes much more thinner and fragile. And when this happens, the bone can easily fracture. In osteoporosis, the bone becomes progressively porous, brittle, and fragile. They can fracture easily under stress. That will not break normal bone. So if a normal bone that has not been subjected to osteoporosis is faced with some amount of pressure, it can withstand. But an osteoporotic bone, because of its porous nature, because of its brittleness and fragility, it can easily be broken with little pressure exerted on it. Osteoporosis normally results in compression fractures of the thoracic and lumbar spine, and also fractures of the neck. So because of osteoporosis, people can easily develop fractures of the neck, can develop fractures of the spine, as well as fractures of the thorax, that is talking about the ribs. Multiple compression fractures of the vertebrae result in skeletal deformity. So if you have fracture of the vertebrae, you know the vertebrae is the one that supports the spinal cord. You have numerous vertebrae. You have the cervical vertebrae, you have the lumbar vertebrae, and we have the vertebrae that is below the lumbar area, around the waist area. So what we are saying is you could have some of these vertebrae developing compression fractures. So they fracture and then they move down. So the person actually becomes shorter than he or she used to be. So what we're saying is when you have compression fractures over and over again, it can result into skeletal deformity. The person can develop scoliosis, the person can develop a kyphosis. So a gradual collapse of vertebrae may be symptomatic. It is observed as a progressive kyphosis, and with the development of these, there is loss of height. So when the person continuously to have one or two, or once a while he has one of the vertebrae getting fractured, the person actually loses height, like I said earlier on. Pathophysiology. Normal bone remodeling in an adult results in increased bone mass until about 35 years. So as we are aging, from age 1 all the way, we have our bones remodeling. They keep increasing in size, and then it continues like this until one is about 35 years old. When you get to 35 years old, age-related loss begins soon after this. So once you get to 35 years old, it means you have peaked in your bone mass development. Your bone will no longer increase in size, but it has peaked. But from there onwards, then it starts to decline. So the size of the bone starts to decline. Calcitonin, which inhibits bone resorption and promotes bone formation, is decreased. So calcitonin is a hormone which is produced in the body, and it is the one that prevents bones from breaking down. This calcitonin helps bones to become bigger. They help bones to build. But when you get to 35 years old, calcitonin starts to get decreasing or decreased. It starts to get inhibited. So as a result of this, it is no longer able to help in remodeling or increasing in the size of the bone. Estrogen, which inhibits bone breakdown, decreases with aging. Apart from calcitonin, estrogen is also another hormone that is produced in the body, most especially in women, and it also plays a significant role in bone development. It prevents bone breakdown, but unfortunately, from the age of 35 and above, estrogen starts to decrease in productivity until the woman gets into the menopause, when it decreases significantly. On the other hand, parathyroid hormones increases with aging and increases bone resorption. So an opponent to calcitonin and estrogen is parathyroid hormone. Whilst estrogen and calcitonin are building the bone to make it bigger, there is a hormone called parathyroid hormones produced by the parathyroid glands. These hormones rather decreases from the beginning. It decreases bone building. It causes the bone it fights against bone building and causes the bone to decrease in size. So whilst calcitonin and estrogen are trying to build the bone, it is also trying to break down the bone. That is, decrease the size of the bone. But unfortunately, when you get to 35 years and above, and when estrogen and calcitonin start to decrease or to decline in its productivity, parathyroid hormone, who is their enemy or their opposer, now start to increase from that age. It begins to increase in productivity. So you can see what is going to happen. The consequence of these changes is net mass or net bone mass loss over time. So because parathyroid hormone is now increasing, and it is the one that will make sure the bone doesn't increase in size, and the two other hormones that helps bone to increase in size start to decrease from the age of 35, this phenomenon actually causes the bone to begin to lose its mass. The withdrawal of estrogen at menopause and with oophorectomy causes an accelerated bone resorption that continue during the postmenopausal years. So the reason why women or females actually develop osteoporosis the more is that apart from the calcitonin that was helping both men and women, they were also having some hormone called estrogen that was also helping them. But unfortunately, from 35 years, it starts to decline in productivity. And then when they enter into their menopause, it totally ceases in productivity. Because from there on, the ovaries are taken out, or not necessarily taken out, but they die off, or they are no longer functionable. That's what I mean by oophorectomy. So the ovaries are no longer working, and they play a significant role in the activity of estrogen, productivity and utilization of estrogen. So when this happens, they do no longer produce estrogen. Calcitonin too has also decreased in productivity. So this worsens their situation. Women develop osteoporosis more frequently and more extensively than men because of one, low peak bone mass and the effect of estrogen loss during menopause. So apart from the fact that they lose their estrogen that was helping in building their bone, generally from the beginning their bone was already not big enough compared to that of men. They were having much more thinner bones compared to men. So a thinner bone, and now unfortunately that thinner bone is reducing in mass because calcitonin is no longer working. And the estrogen that was also helping you is also decreasing or has totally stopped. So you can see why their situation gets worse from that time on. More than half of all women older than 45 years of age show evidence of osteoporosis on X-ray. Risk factors. What are the risk factors of osteoporosis? Women experience osteoporosis greater at an older age. Nutritional deficiency of vitamin D necessary for calcium absorption and for normal bone mineralization. Dietary calcium and vitamin D must be adequate to maintain bone remodeling and body functions. The best sources of vitamin D is fortified milk. Immobility contributes to the development of osteoporosis. So people who are immobile, in fact, the more you move, the the more your bone gets blood transfusion or perfusion, and that improves the viability, stability, and the strength of the bone. But if you are immobile and you are stationary or you are bedridden, let me put it that way, you lose that adequate perfusion and the bone is not being physically challenged in order to improve its formation. Medical conditions such as malabsorption syndromes, hyperthyroidism, hyperparathyroidism, etc. So medical conditions or disease conditions such as malabsorption means that though you eat adequate nutrients, but your body is not able to absorb the nutrients. So you eat the nutrients and the nutrients will pass out as stool without the body absorbing it. So when that happens, in as much as you are eating, the body is not getting the adequacy of these nutrients that will help in bone development. Then we have hyperthyroidism. In hyperthyroidism and hyperparathyroidism too, there are factors which in hyperthyroidism you have the productivity of your, I'm talking about hyperparathyroidism, the productivity of your parathyroid hormones increasing. When you have too much hyperparathyroidism, you know, we said hyperparathyroid hormones are the ones that decreases bone formation as against calcitonin and estrogen. So if you have high levels of hyperparathyroid hormones or the hyperparathyroid glands secreting too much of the hormones in the blood, then you are going to have too much of hyperparathyroid hormone in the blood. And when that happens, it is increasingly going to cause decrease in bone production or bone development. Then we have exercise. Exercise. Bone formation is enhanced by the stress of weight and muscle activity. So when you exercise, you put pressure on the bones, and this helps the bone to enhance itself, to improve, and then to become larger. But if you do not exercise, so compare somebody who has been going to the gym and gymming and another who has not been going to the gym. So the one who has been going to the gym and regularly exercises and lifts and works on the bones, they tend to grow bigger. Not just the muscles that enlarges, the bones also increase in size. Whereas if you are not using the bone, then the bone will lose in its size. Certain medications such as corticosteroids, isoniazid, heparin, tetracycline, aluminum-containing antacids, furosamides, and thyroid supplements affect the body's use and metabolism of calcium. The degree of osteoporosis is related to duration and medication of the therapy. So all these medications that I've mentioned will affect the body's ability to absorb calcium and to utilize it. So they will not allow the body to be able to use calcium well. And if calcium is not utilized appropriately, it is going to decrease or have effect on bone formation. So what we're trying to say here is that excess use of the above medications will also go a long way to deprive your bone from its proper formation, and this could lead to osteoporosis. Diagnostic investigations. How are we able to diagnose or confirm that the condition we are seeing is osteoporosis? We want to do our x-rays, bone scan, MRI. We want to do blood tests, that is serum calcium, serum phosphate. We want to do urine calcium excretion. So we want to do our urine test to see whether there is calcium in it or not. Management. How do you manage osteoporosis? You encourage balanced diet, that is rich in vitamin D, more especially because vitamin D plays a significant role, especially in absorption of calcium. Regular weight-bearing exercises. So the more you exercise, as I said earlier on, the stronger and bigger your bones become. Intake of calcium supplements, and then treat underlying medical conditions. We want to administer prescribed medications such as biphosphonate. They increase bone formation and decrease bone resorption. At menopause, hormone replacement therapy with estrogen and progesterone may be prescribed. So like I said, in women, estrogen plays a significant role in bone formation, but unfortunately when they get to menopause, they are no longer able to produce this hormone. In the advanced world, where people have the access and have the means, they regularly visit their medical providers or healthcare providers who inject them or give them supplements as in terms of these same hormones, artificial estrogen and progesterone. When they are given these artificial hormones, they help to boosting the bone, just like how the natural estrogen was doing. So these tend to decrease their risks of developing osteoporosis. So your reading assignment will be to read on bone tumors. Bone tumors. Make sure you read on it, prepare your lecture notes on it, and then you will submit it for marking. Thank you.